多謝晒。好啦，咁我哋事不宜遲啦，我哋就進入今日嘅第一個 section 咧，就係我哋嘅 keynote lecture. So, without further ado, we would like to kick off our keynote lecture section. So we're very happy to have Professor Roger Zhong with us today to be the first speaker. 我揾Professor Roger Zhong 嘅時候咧，我就email 佢，因為我知道咧佢係一個好 dedicate 嘅一個嘅 scholar 咧，其實係探討好多有關 health equity 嘅呢個 issues 嘅。So when you look at our topic, we said like from science to society, addressing disparities in HIV and sexual health. 要明白咩叫 disparity 咧，其實我哋有啲 basic 嘅 concept 係要去一齊去研討一下嘅，包括譬如可能係我哋講啲 social determinants health equity 等等。So I'm so happy to have Professor Zhong today to share with us and equip us with all this knowledge to do our work. So Professor Zhong is Associate Professor, JC School of Public Health and Primary Care, the Chinese University of Hong Kong. He is also a co-director, CUHK Center of Bioethics, and Associate Director, CUHK Institute of Health Equity. He will share with us the knowledge and concepts on health equity. Professor Zhong, please. Thank you.
I'll be using this one, right? Yeah. Okay. Hello, everybody. Good morning. How's everybody doing? Well, good morning, of course. Ladies and gentlemen, it's really my honor to be delivering this keynote address. Oops. For today. I'm so sorry about this. I'm a little nervous. But this is a very important topic. When I got the invitation from NIDA and AIDS Concern, they asked me to give a perspective from the health equity angle to look at HIV and AIDS and sexual health. So this is what I'm going to do today. If you haven't heard about health equity, this is good because I'm going to make a case for health equity to look at sexual health today. And if you have studied or encountered this topic before, this may be familiar to you, but it will serve as a recap of some of the thinkings in health equity. So health equity matters is what I'm trying to get at today. And this is the aim for today. I'm going to describe the phenomenon of health equity and inequalities and introduce the concept of health equity to make a case why it matters and to illustrate the concept of social determinants of health. To argue why we should go beyond just the more conventional distributive justice to address the social determinants of health and to describe some strategies, overarching strategies to address social determinants of health. And at the very end, I will pose a challenge to every one of you today. So thank you, AIDS Concern, for the invitation. I would like to acknowledge my colleagues, research team, and PhD students, and also the Institute for Health Equity, and also the funders for my research work. So, health inequalities, 健康不平等, okay? So, let me give you some empirical evidence of health inequalities. So, this is health inequalities when you zoom out, right? This is global health inequalities. As you can see over here, this is on the x-axis is the GDP per capita, the wealth of a nation, and then on the y-axis we have the health of the nation as measured by life expectancy at birth, right? As you can see over here, if you increase the GDP per capita for a lot of these developing countries, then the health indicator just skyrocketed, right? But then there will be a turn and it will plateau even though there will be slight increase afterwards, right? But then it will only increase just a little bit, okay, for the developed countries. And this is famously called the Samuel Preston curve. Now, if we zoom in to some of those richest countries, as we see, they kind of plateau, what we see here is that if you put income inequality on the x-axis and the y-axis the same, health indicator, health problems, you will see that if the society or the country is more income unequal, right, the Gini index is higher, right, then actually there will be more health problems. The people will tend to be, on average, less healthy. Then if we zoom in to one of these developed countries, and in this case, this is the UK, all right? And the little dots are the neighborhoods. And on the x-axis now, we have the neighborhood income deprivation. So if you go along the line of the x-axis, you'll become least deprived, okay? The more deprived are at the left-hand side. On the y-axis, we have the life expectancy. We see a couple of things. Number one is that deprived people, they die younger. And number two, the deprived people also suffer longer from disability. So they start to have disability younger, they live a longer life with the disability, but also die younger, right? So we call this a socioeconomic gradient in health because it's not a dichotomous concept. It's not like, oh, you're poor, then you will be worse. It's like talking about this gradient, 一個梯度, okay? As you go along, as you get wealthier, right, you're going to get healthier. So it affects everybody. The whole idea about socioeconomic gradient in health is that it affects everybody, not only those people who are labeled as poor. This is the US. We see very similar things, right? Income on the x-axis, again, as you get richer, the percentage of people reporting poor health gets lower. And in Hong Kong, what about Hong Kong? Okay, so these are some of those papers that we have done and a lot more, but I'm just highlighting some important key findings from my own research with my research team. We found that in Hong Kong, deprived people have worse general health than their richer counterparts. 66% of them are more likely to have worse physical health, and 83% are more likely to have worse mental health. The deprived also have greater risk for chronic diseases and multimorbidity, meaning multiple chronic conditions. Right? People of education attainment of primary or below were 28.7 to 68.9% more likely to suffer from multimorbidity. People with income less than median household income were 43.3% to 52.2% more likely to suffer from multimorbidity. Jobless people were 63.9% more likely to suffer from multimorbidity. And compared to smoking, which a lot of people know that is a public health hazard, it's only 36.7%, relatively lower than the deprivation, the harm of deprivation that it's going to do to you in terms of health. Now in Hong Kong, if you divided it by the 18 districts, we also see that if the district median monthly household income, as it increases, life expectancy also increases. So it kind of matters where you live, but probably a causal, it's a reverse causality. The people who are richer, they tend to live in richer neighborhood, and therefore they also have better health, longer life. This is another way of looking at it. Income, again, as it increases, we also have the percentage of people reporting poor health getting lower, and we also call it a socioeconomic gradient in health. This is healthcare inequalities, right? Deprived generally have worse healthcare accessibility, about 2 times less likely to have regular source of primary care, that is your family physician, a first contact primary healthcare provider. All right. And if you're interested, you can download, these are online. We have, in this Institute for Health Equity, released a series of health equity reports looking at generally the socioeconomic inequalities in health, and then from a life course perspective. And then our third report is on environment and health inequalities in Hong Kong, and there will be more. And the next one, in the future, we're actually going to look at gender inequalities also. So these reports are actually done in the tradition of, one of the most seminal health inequalities report, the Black Report in 1980, which really put the whole agenda of health inequalities on the map for the first time. It was published in the UK by the UK Department of Health and Social Security, and is chaired by Sir Douglas Black. This is Peter Townsend. Oops, sorry. So there's no laser pointer for this, right? Okay. So there's Peter Townsend, okay, who actually was known as the guru of poverty research. You have to understand that back in 1980, at the turn of the decade, from 70s to 80s, a lot of people thought that they have won the war against, the most treatable infectious diseases. They have really won the battle against, diseases in general, and they believe that, with research and innovation and technological advancement, they can solve any problems. And in the UK, they have the National Health Service, and a lot of people were thinking, health inequalities, that's not possible. We have, one of the best healthcare systems in the world that is almost free of charge, run by the government, supported by government revenues and taxation. How could that be? Everyone can access healthcare. But lo and behold, with the inequalities in health, it was revealed that there are a lot of inequalities. And whether you're talking about infant mortality, we see the same thing, same patterns across different causes. Sorry for the low resolution, because I actually I scanned this out of the original Black Report, right? So the lower the social class, the less healthy. Whether you're babies or adults, we see the same pattern, right? Same pattern across different causes of death. The lower the social class, the less healthy, the higher the mortality rates. So people were shocked. So remember Margaret Thatcher. Margaret Thatcher was trying to kind of shove it aside because, she just gained power during that time. And the media picked it up, and they're waving the Black Report in front of her. So that was why health inequalities, for the first time in history, was put very firmly on the map. So that was the history. That was some empirical evidence of health inequalities. Now we're moving on to the next concept, health equity. 健康公平啦, okay? So basically the question that we're asking is this: are these inequalities that we have observed unfair? 係咪唔公平嘅呢？呢啲嘅不平等。So let's make a quick distinction between the two concepts. Inequality and equality are dimensional concepts, usually referring to measurable quantities, differences in quantities. On the other hand, when we talk about inequity or equity, these are ethical political concepts. Right? There is a moral commitment to justice, 公義, okay? So it is an ethical issue, 係一個同倫理有關嘅一個概念嚟嘅。Justice. In the words of Sir Michael Marmot, who is very well known in this area in health equity research, this is, paraphrasing what he always say. When health inequalities are remediable, meaning treatable, but they're not treated, not addressed, not remedied, then they're unnecessary and therefore inequitable and unfair. Meaning, if we have the technologies, if we know the answer to cure people's diseases, but somehow they wouldn't be able to get it, they couldn't access it, and they're disproportionately affected by certain health outcomes, that's unfair because we know the answer. So here's the normative ethics question. Normative ethics means we're not basing these arguments on just empirical observational data. We're actually making an argument 一個同倫理有關嘅 argument, okay? Normative ethics questions. And I got asked this a lot when I was doing, throughout this past decade of doing health equity research in my work. People would ask you this. Inequalities exist everywhere, right? This is our world called planet Earth, right? And it is very unequal, and we know that. So why does it matter to you that you have to do all these health equity research? Let me try to answer this question. Well, we have to look at some guiding principles. We cannot just be all skeptical or even cynical about this, right? So how do we move from cynicism to reality to progress is going to be the theme for today's talk. Well, one of them, I would say, well, let's look back at some of the guiding principles of biomedical ethics. In 1970s, by the end of that, Beecham and Childress released a book that is one of the most influential ones that we still use in medical curriculum to this day, called The Principles of Biomedical Ethics. And in that, they have outlined 4 what they called equally basic moral principles. Sometimes these principles can come into conflict and create moral dilemma, but nonetheless, they are very important, okay? Basically important that they say would be universally agreed upon by all people. They are respect for autonomy, 即係病人自主 respect 佢嘅自主 non-maleficence, that is the do no harm principle, 即係唔好傷害 beneficence, 要個病人得益 okay? Beneficence and also justice, 公義 okay? So we don't have to apply this only in clinical settings. We can also apply it on a societal level, especially when we're talking about public health, 公共衛生. Justice is what we're talking about today. It is one of the guiding principles, right? So let me go back a little bit to the definition of health, right? How do we look at health? And I really appreciate the outline for today's conference, that we are splitting it up into 3 dimensions: physical, mental, and social well-being. And let's not forget, not merely the absence of disease or infirmity. Now, on the other hand, this is a 1946 definition of health, first time that WHO, under the umbrella of United Nations, experts come together and formulate this definition. It's an important definition because it is emphasizing that health is not just about the physical. As a lesson from the Great Wars, actually, they understand that it is also the mental health and the mental well-being and also the social well-being of the people that really matters. And then, 40 years later, they further clarify this: health as a resource for everyday life. 係個資源嚟嘅 not the objective of living. 唔係生命嘅目的 okay? That's important. Health is a positive concept emphasizing social and personal resources as well as physical capacities. Because what they're trying to argue here is without health, we cannot pursue our life's goals or happiness. I think that's a very compelling normative argument there. And the argument is that is one that is based on justice and that health is a basic right. Health is a basic right. That's important, right? And the consensus is that each of the states around the world, nation states I'm talking about, have an obligation to protect and promote the health of their citizens, and in some cases, the health of non-citizens within the borders. And it is codified to include everyone, not only citizens, okay? We have the Article 25 of the Universal Declaration of Human Rights, Article 12 of the International Covenant on Economic, Social, and Cultural Rights, and also the General Comment 14 of the UN Economic and Social Council. All right, this is Eleanor Roosevelt reading this out. Everyone has the right to a standard living adequate for the health and well-being of himself and his family. Quote, right of everyone to the enjoyment of the highest attainable standard of health. And here we have in the UN General Comment, the right to the highest attainable standard of health. So these are codified and so influential that in 1978, they created also the Declaration of Alma Ata, Health for All, which is adopted at the International Conference on Primary Healthcare, and it was the first declaration emphasizing the importance of what we call PHC, now very well known, primary health care. All right? And this approach has since been accepted by all the member states of the WHO as the key to achieve the goal of health for all in all countries. And it also gives support to the policy direction of what we now call universal health coverage. But here, let me contrast UHC, which is universal health coverage, with primary health care. They're a little bit different because PHC is bigger than UHC, okay? UHC is one way to approach and try to achieve primary health care, but it's a little bit different because PHC is more encompassing. It extends beyond just the traditional healthcare system to other areas that promote health, including social policies, environment, lifestyle, etc. So, what do we have in Hong Kong? Here we go. Hong Kong, this is the overarching healthcare policy in HongOng. No one should be denied adequate medical treatment due to lack of financial means. 中文係沒有人因為經濟原因得不到適切治療. All right? So let's take a look at this healthcare policy. It is a policy based on the concept of universal health coverage. All right, so in Hong Kong, we do have universal health coverage because all the residents in Hong Kong can actually go to the public healthcare sector and get your treatments, and you will not be denied adequate treatment due to your financial situation. But we do have to try to answer this question. Now, how many people in Hong Kong are denied adequate health care due to lack of means? Are there any people who are denied directly or indirectly due to their lack of financial means? 即係有冇人因為經濟原因得不到適切治療啦？香港 You want to take a wild guess of the percentage? Anyone? I heard 20. Well, that's a little bit high, I would say. I heard 10 somewhere. It's around there, okay? So according to our study that we've done several years ago, it was 8.4%. I would say that this is estimated because the people who actually pick up the phone call or agree to do household survey, they are usually a little bit more open, right? So we are probably missing those people who are almost invisible in our society. 8.4%. Some people would say, that's not too high, but you know, if you do a calculation, that is 600,000 people, more than that, probably even approaching 1 million people if we say that it is underrepresented, underestimated. All right. So there are people, right? And again, this is universal health coverage in Hong Kong. There is universal health coverage in Hong Kong, but not achieving the goal of health for all yet, okay? Because PHC, again, is bigger. Primary health care goal for health for all is bigger, right? It is a passive, not an active system because it is based on a non-denial rationale. But that's fine, okay? Because, you know, that is how services work, right? You have to show up to the healthcare system. And what is adequate? Adequate according to whom? And last but not least, this is the emphasis for today's talk, right to health care, right? Not right to health. It's really emphasizing on the healthcare bit, which is talking about distributive justice, not necessarily the broader social justice. So here's an empirical ethics question. Why would health inequality exist even with universal health coverage? Then we have to understand this concept over here. So in this allegory, imagine yourself walking on, alongside a river. You're just strolling along, and then you heard someone crying for help, in the river, because you have taken first aid, okay, and lifeguard lessons. You jump to the river, save the person's lives. You feel very good about yourself. That person also thanked you for saving his life, okay? But then 5 minutes later, there's another person. You do that again, you pull it up, but you're wondering, why are there so many people drowning, right? And the third person and the fourth person, you kept doing it, and then you're like, what's going on up there, right? Because river flow from upstream to downstream, so you look up. You look at the upstream, and then you realize that there are people who are systematically being pushed down the cliff, right? So that's the allegory. On the downstream, what we're doing here are services, healthcare services, but there are these structural determinants of health, right? And this is what we call social determinants of health. 健康嘅社會決定因素, okay? Dated back to 1998, Sir Michael Marmot and Richard Wilkinson, two very important people, were commissioned by the WHO to come up with the first publication to summarize all the major work on social determinants of health to provide a guide. All right, so the SADA Facts, a seminal report. And with this commission, they came up with a framework for the social determinants of health, which I would like to spend just a little bit of time talking about, okay? So usually when we talk about the downstream factors, we're talking about material circumstances, behaviors, biological factors, and psychosocial factors. These are the usual point of interventions. Now, with social determinants of health, they are pushing it a little bit to the upstream. They are talking about these over here. Structural determinants of health, including governance, the policies. We're talking about not only healthcare policies, but also macroeconomic policies, labor market policies, housing and land. I mean, when I talk about housing, then everybody in Hong Kong would be like, yes, of course, housing affordability and health, they are related. And I have actually published a paper talking about that. So if you're interested, let me know. Education, social protection, and also, last but not least, culture and societal values. All these things would give you a distribution that is unique to your society of socioeconomic position that are going to be proxied by social class, gender, ethnicity, education, occupation, and also income, okay? Now, two things that I would like to emphasize. You see that health system, it's in the downstream. It is put over there on a purpose to remind everybody that people get sick, then they show up in the health system. So therefore, it is in the downstream, okay? In the upstream, we're talking about these policies, these governance, and last but not least, culture and societal values that I would like to say something about today. This is the Chinese version. If anybody want to, take a quick snapshot, please go ahead, okay? This is translated by myself. Okay, all right. Addressing it. How do we address it? How do we address these social determinants of health? And I think we have to think beyond distributive justice. 超越資源分配公義. You would realize that the WHO, when they released the 2008 report, it is actually directed to the government, right? These are policy-level recommendations, improving daily living conditions, tackle the inequitable distribution of power and money and resources, and also doing evaluation. can we go beyond that? I like this illustration because I think I personally like it better than the baseball one that probably a lot of you guys have seen. Now, this is inequality. No two, there's one with more resources. But if you give equal tools to different people, still there's equality, but not actually equity. Okay, so here you go. So someone is getting a longer tool. And we say that, well, that's more resources. That is distributive justice. But a lot of times we forget about the fences, the barrier. The barrier are the social determinants of health, and we need to think beyond distributive justice to tackle them so that we can live in peace. And one thing that I always like to say is that justice is not a stagnant state of affair. It is a goal that we always have to pursue after. There's this ideology, this ideal form of justice that we have to pursue, but doesn't mean that the little progress that we made are unimportant, right? So there's no case here for complete cynicism and say, well, there's no justice in this world, so why pursue it? I think there's a strong case here because justice requires us to make little progress at a time, and that is fine, I think. So there are two overarching recommendations that I would like to give today, okay? So these are from public health and also from social studies, social sciences. The first one that I would like to talk about is this idea called population health strategy by the great Jeffrey Rose with his strategy of preventive medicine. So he kind of contrasts the high-risk strategy with the population health strategy. The high-risk strategy are actually intervening with those with high risk. He said, it is great, but the caveat is that you're only intervening with people in the upper end, right? It is much needed. They need the help and the interventions, treatments and managements, all that. But he believed that if we can shift the distribution, we will help more people. And that is probably what we really need. I think health equity really lends itself very well with the population health strategy because what he's saying is that we need to shift the population mean and the distribution from a more harmful environment to a less harmful environment. And by that, I not only mean physical environment, but also the social, cultural, and political environment. And the second one is from social science and gender studies, which I like it very much. It's from by Iris Marion Young. It's called The 5 Faces of Oppression. 壓迫的5個面向. It is beyond distributive justice because what she's trying to address is that there are other forms of injustice in our society that takes the form of exploitation, 剝削, marginalization, 邊緣化, powerlessness, 無力感, cultural imperialism, 文化大國主義, and also violence, 暴力. And I don't mean just physical attack, but also verbal abuse, harassments, petty harassments, and different forms of violence that we can think of. So with that, we need to ask these questions, right? With exploitation, who are being exploited in labor that harms their health? How? Marginalization, who are being regarded as not deserving the same level of health protection as others and thus deny equitable access to resources, opportunities, and recognition? Who are being dominated by, say, capitalists, we do live in a capitalistic society, and professionals in institutional labor relationship, and how can that affect health? And Mr. Chu was just talking about job termination, right? This is something that we have to think about. Cultural imperialism, whose perspectives are being rendered invisible by stereotyping and marking them as the other by the dominant culture, and how can that affect their health? And 5, who are being physically attacked, harassed, intimidated, ridiculed, as a result being degraded, humiliated, or stigmatized. And are these acts somehow was legitimized to a certain extent in our social environment and culture. Sorry, I ran a little bit over time, but here's the conclusion. All right. I like to think of it this way. What does it mean by taking a health equity perspective? I deliberately wear my pair of glasses today to illustrate this, okay? We can always take off our own glasses, which probably represent your own perspective on things, that the usual ones that you take, and take on different ones. So we can take on, for example, infectious disease and treatments perspective, cure perspective, technological advancement perspective in terms of vaccination, right? These are all perspectives that are very well known in the HIV and AIDS and sexual health realm. Security, of course, and economy. Yes, for a lot of those developing countries especially, they really affected security and economy. You can take on the lens of resources and cost effectiveness, but also today I'm advocating for a lens, a perspective of health equity. You know, take off the other lens for just a little bit while, take the health equity lens and look at the problem at hand. And what you will see is that there are two things, right? High risk, as Jeffrey Rose put it, then we'll be focusing on socially disadvantaged and vulnerable populations, but at the same time, we can take a population health approach. And then the concepts that we've talked about will become very apparent with this approach. Socioeconomic disparity and gradient health and social determinants of health, including the structural determinants, and also that we have to change the social environment beyond just distributive justice. Here's some skepticism in addressing social determinants of health. Some people would say, well, not everyone is a policymaker. I'm not one. Well, we can always lobby them with a bottom-up approach. Only policies can change the distribution of wealth and socioeconomic position in the societies. Well, yes, but aware of these inequalities matter in our services. They can be taken into account. And here's a myth. Addressing social determinants of health is only a matter of distributive justice. And today I say, no, it goes beyond distributive justice to address the different phases of oppression that these people may face in our social environment, and these are very relevant to sexual health. So here are the take-home messages. Health inequalities exist across countries and within countries. It is a matter of justice to address these health inequalities. Social determinants of health should be addressed in both upstream policymaking and downstream services. And addressing these SDH is beyond the matter of distributive justice of healthcare resources, and we need to look at the broader social justice. So what's next? All right, how do we address SDH strategically? Well, we can look at what other people have done, and this is United Nations UN AIDS, Global AIDS Strategy in 2021 to 2026, and they have come up with a new approach, leveraging on 4 decades of evidence, and they believe that what's stopping the end of this HIV/AIDS pandemic is because of this lack of focus on reducing inequalities, right? Because inequalities facilitated the spread of the pandemic. And they have looked at the structural determinants of health, of HIV vulnerability, and identified key populations also. And of course, we also have the Hong Kong's HIV and AIDS strategies with 8 key strategic areas and also priority populations. We can all base our assessment on what we already have, okay, in the world and in Hong Kong, and think about this question here. Okay, based on what we have and the situation in Hong Kong. How would addressing the social determinants of sexual health specifically look like in the context of Hong Kong? This is a challenge that I would like to pose to everyone today, okay? I think everyone should try to answer this thinking about your own role, your own duty, your own responsibility, okay, your own position. what can you do to address the social determinants of sexual health in Hong Kong? And these are just some examples, but it can go beyond that. Okay, so thank you very much. And here's my contact and all that information. Thank you very much for giving the time for me to talk about health equity of sexual health. Thank you.
Professor 總會拉到個咪好低。Yeah. Thank you, Professor Zheng. That was a really powerful keynote to share the concept of health equity and so all the key concept of justice. I'm still digesting. It's a lot of concept, but I think it really touched the theme of today and help us to think more. Just not only stay on knowing about the knowledge and prevention strategy, but really think deeper of the issues. Okay, so now we would like to invite Dr. Ho Kingman, and the chairperson of Hong Kong Advisory Council on AIDS, to share with us the evolving landscape and the emerging challenge in the HIV/AIDS work in Hong Kong. So we'll come to the topic on our home city, to see what's happening and any of the challenges and opportunities in how we deal with the issues of HIV. So Dr. Ho, please. Thank you.
First of all, thank you for the invitation of AIDS Concern. Sorry. Okay. Thank you very much for the invitation of AIDS Concern to invite me to share with all of you and some of the work which is initiated by the Advisory Council on AIDS (ACA) in the past, and we are looking forward to actualizing some of the strategic recommendations in the coming years. But to start with, I really enjoyed the lecture of Professor Zheng. Okay, to give you some kind of information, I just write a very little article and submitted, which is one is divided into two, is about 健康公平. Okay. There's health 健康公平 in the Hong Kong Economic Journal. Is Sun Bo. The first part has already published, but the second part will be published, I think, tomorrow. Okay, you may go to the website of Hong Kong Economic Journal and use my name to Google to search, and you may read my very short, humble article concerned about 健康公平. To start with, when I wrote an article, which is a CME article submitted to the Hong Kong Medical Diary, on HPV vaccination, okay, and dating back from many years ago, okay, and I think this is more than 20 years ago. The term health equality was used many years ago. Okay, I read the term health equality, but somehow in the recent articles, the term health equity was used. Okay, it comes across my mind. Why? What is the difference between equity and equality? I start to search in Google, and I learned a little bit of the differences between. I read the three photos, the baseball, the football with the fences, okay, and use it as an example to illustrate what is the differences between equity, equality, equity, and eventually what is meant by justice. Okay, I mean, in the context of HPV vaccination, we're talking about what is targeted. In the country, we are vaccinating the primary school girls only. Okay, the P5 the first dose is P5 and the second dose is P6, primary 5, primary 6. But we're talking about whether we need to have a catch-up program. We're thinking of whether we should implement a so-called gender-neutral vaccination, and that's what about the health equality and equity. And the little article I submitted to Hong Kong Economic Journal is about the access to the very expensive no-food treatment for a skin disease, psoriasis. Okay, is is it what happens to this group of patients, the access to this type of novel biologic treatment. Okay, if you're interested, you can go and to have a read and give me some kind of feedbacks to let me learn more. I learned a lot from Roger this morning. Okay. Okay. Yes, next slide. Nick. The green button. Yes. Thank you. Yeah. Yeah. Okay. 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 This is my background. Yeah. No, because given the interest of time, I will make my presentation very quick because of, well, some of these important concept have been gone over by Professor Zhong. Okay, this is a quick revision of current landscape and HIV, ACA, Hong Kong AIDS strategy 2022 and 2027. And this is the latest. Okay, this is this is the local HIV/AIDS epidemiological data. Some of the epidemiological data. You may notice that at 2015, the peak we have just passed the peak of the HIV. And in GIST, this is a summary table. I like to highlight some of some of the important key messages in this table. It says male is the predominant group of people infected with HIV, but we have a substantial portion of female. And then most of these local cases are ethnic Chinese, and the route of transmission is through sexual contact, in particular through men who have sex, amongst the MSM. We have a small proportion of people contracted HIV through needle sharing, the people who injecting drug, the people who inject PWID. And the mother will have a sporadic report of mother-to-child transmission. Okay, and this is a summary of the extract of this from some of the table. And the preference of the local study by PRISM is a local study, which is the estimated preference of HIV positive among the MSM communities is about more than 6%. Okay, but one of the important observations in our data is more than 40% of local cases are late presentations. Okay, late diagnosis, late presentations. And the performance of the treatment cascade in 2020 is roughly, the denominator is 8,000 people living with HIV/AIDS, and 94% of those people living with HIV/AIDS were aware of their positive HIV status. But I have a puzzle, but I'm not quite sure how to explain. Should the percentage is so high, 94%, how to fit in the data, the observation of more than 40% of them are late diagnosis? There must be some kind of missing knowledge gap between these two figures. We have to look into it, to explain the so-called seems to be a little bit discrepancies. And 84% of these cases, they have access to already started on antiretroviral treatment. Okay, but supposed to be more than 90% because it is very likely those who do not started on the ART in the local medical health services, they may not be the long-term local Hong Kong residents. So they have a positive test, but somehow they will leave Hong Kong. So I believe that this indicator we are also achieved the 90% 90% goal. 90% of those who are on treatment has been the virus well suppressed. And up to date for those who are working not in the non-local in this room or maybe some other internet. okay, internet. In Hong Kong, the government provide antiretroviral treatment. It is up to standard. Okay. It is almost in the forefront according to international standard, at nominal charge. Okay, the charging policy in Hong to this group of people is something like as if we're taking care of patients with diabetic hypertension with the nominal charge. Okay. And even then, we provide, there is a safety net. This is free of charge. Should they pass the means test by the social welfare department, the level of support. And just Bonnie gave us the inform the audience that there is a developing one-stop comprehensive medical link up to prevention, medical care, and everything. As software is developing in the special preventive special preventive program. They're developing. They're getting add on more and more with the gain of experience. And if you're interested, I would give you. If you are interested, you may just contact Bonnie to ask for a visit. Okay, ask for a visit to the Yattong clinic. Okay, should you have a good link with the MSN community? I think if Bonnie will welcome the visit by the MSM. Okay, for the service. Okay, am I right to say that, Bonnie? Yes. Okay, and this is the quick highlight of the current landscape. This is the shot of the so-called the players, the key players. Okay, this you may read. Okay, you may read from the strategy published on the internet, but I give you a highlight. This is a CHP Center for Health Protection, DHR Health Bureau, another government. The SPP, the Special Preventive Program, provides, it's a clinical program, public health program, clinical program, public health program, provides the policy support researchers, and also to support the scientific committee on AIDS and STI, and the advice and the part and partial before it is fully supportive the AIDS Trust Fund. But now we also support, but slightly different. But the CHP have a separate team to support the ATF, the AIDS Trust Funds. Okay. And the clinical services are also provided by PMH and Queen Elizabeth Hospital. And there are other, it's not directed to people with HIV, but some people at risk, the so-called vulnerable population. Okay. This term, vulnerable, may not be so welcomed by some of the workers or the people themselves. But I still use these old terms, okay? And the social hygiene service and the narcotic division administration, the methadone program, the tuberculosis, the TB and chest services, social welfare department, education department, they are all providing different kinds of, they have participated in the local HIV programs in different manner. And the advisory council on AIDS, okay, we have from stakeholders from various backgrounds, including Professor Sun, okay, from the CUHK. You know all this, Professor Sun. He is an academician with interest in gender issue and sexuality, okay, and a wide participation by different backgrounds. And the advice the AIDS Trust Fund. Well, the AIDS Trust Fund there is three regular committee and one special project fund, which is an ad hoc one. And the EGP, it means the ex gratia payment. Okay. Ex gratia payment committee and the publicity and public education committee and the medical service and support committee. These committees are represented. The committee member are represented by, okay, and chair and represented by mostly non-governmental members. As it's a little bit, this is not 100% governmental. Not 100% governmental. They do all this vetting to vet the project submissions and then grants the funding to support these activities. And from the financial year 1993 up to the financial end of financial year last year, okay, slightly less than 1 billion, less than 1 billion have been already funded to support various projects, okay, including all these in work concerned about people living with HIV/AIDS, people who injecting drugs, ethnic minority female sex worker, and the male client was female sex worker, the transgender, and others. And this is some of the more than 2 million condom has been distributed. But in fact, much more than that. Okay, this is the condom distribution. This is all funded by AIDS Trust Fund. But there, a lot of the NGOs, they have received support from the other funding, including, the famous condom producer start with the D. Okay, okay. They donate in some point of time to donate the condom to the NGO for them to distribution. So the condom distributed should have been much more than above 2 million, and in context of outreach, and more than 700,000 HIV tests has been performed. As I said, should be much more than that, because some of these testing are not directly supported by ATF, but initiated by the NGO themselves. And this is but the point is these funding projects, this funding project not written here, is plot by project and by project basis. It causes some of the challenges of the NGO. Okay, what are the challenges for the NGOs? It is, whether it is very difficult for the NGO to have a relatively long-term planning, staff development, okay? And very difficult for the NGOs to train the staff, to retain the staff, Yes, neither, not his. Okay, this is the challenge, okay? We have the NGO participate lots, very important stakeholders. Mainly in the local program is the so-called AIDS, the NGO with specific interest in HIV/AIDS. The participation of the mainstream NGO plays a small part, okay, mostly, as up to date. And but connectors, the NGOs are very, very, very important. Where the people, the guy who really directly reached to the community people, and if they do the frontline work, okay, they really go to the bars and saunas, and to directly talk to say an MSM, talk to the attendants, the service user of this sort, the gay bar or the gay sauna. Okay, from one time, this is a story. That's some years ago. Okay, the controller of Center for Health Protection, okay, said to me that, okay, well, Dr. Ho, you can actually go to if you are being invited to the gay bar to give a short talk about HIV/AIDS prevention or whatever, you are welcome to do that, okay? Okay, but eventually, somebody asked me and I filed an application, and it is not so welcome, okay? Not so welcome. After very serious consideration, as a government officer, they at the high level, they have the really other considerations of inviting of a government officer to present to a talk directly to go to gay sauna to engage in this health promotions activity. Okay. And the NGOs, in particular, is concerned. Okay, they have very innovative idea. They're very innovative idea in their promotional material, which is quite welcomed by the community people, such as the Tong Sing. Remember? Okay, Tong Sing. Okay, okay, John, you know Tong Sing, the Tong Sing, and 恭喜你有梅毒. Okay. Okay. For somebody who doesn't understand what is the Tong Sing, why is it so interesting, and what is 恭喜你有梅毒. Okay, the AIDS concerned worker will explain to them why it is so innovative, so interesting. Instead, some of the older the government produced that we our staff could be quite innovative, but at the same time, we are very safe. We have to be very careful not close a little bit the line, and then otherwise, well, we will be in trouble. And this is innovation, and the NGO, they have a advocacy role, okay. And for the advocacy, to sidetrack a bit, here, I will talk about the slide later. Once show the messages in this slide later. Okay, the target of your advocacy work. The target of your work is who you are going to lobby, and what are your target audience? What are the target audience? I suppose your target audience is not Donnie. It's not me. Okay, because we are in the same team, in the same boat. We're same boat. We know everything. Okay, you have to. Okay, so in your advocacy work, remember your strategy. Okay, your strategy. Okay, and the challenges, we have long list of challenges. Long list, I saw the dot in the front and dot at the back of this in this bullet point. Long list, and but I just highlight some of the very important challenges. Is include engagement of and support by stakeholders who actually have interest but not interested. The first interest is 切身關係, 利益關係. Okay, who are these stakeholders who have the 切身關係, 利益關係? Everybody you do. The local society, everybody in local society, including the common people, the lay people, including the government officers, including the management of the big giants, the industry, the pharmaceutical industry, and the commercial industry. Everybody, they should have 利益關係, 切身關係. Am I right? Okay, but not interested. Okay, you know what I mean. Okay, these are the important stakeholders. Okay, they're not interested, 不感興趣. We have to do that. Okay. And social marketing of the whole HIV/AIDS program. We are not very successful, say, in Thailand. In Thailand, they have launched a very successful condom social marketing, okay? Okay. The terms, I learned this term social marketing, dating back from sort of 30 years ago when I started in my HIV, when I was, deployed to SPP, to engage in HIV work. Okay, interesting term, social marketing, the condom social marketing. But it is not only the social marketing, not only limited to condom promotion, but for the whole HIV/AIDS program. Okay, this is very challenging. And the direct and active involvement of the targeted community people, the community people themselves. And we have to engage them and obtain their support. Okay. These are the important challenges. And this is the current HIV response in Hong Kong. You know, the big circle is the whole society. We are, the people at risk is a subset of the people in the whole society. Now we're doing the promotion, the behavioral change, the change of behavior, the content promotion, the empowerment and everything, testing, and providing the HIV combination prevention, patient center, harm reduction, approaches, and then eventually pick up, that first diagnosis who have HIV, and link them to treatment, and then we can use the prevention, treatment as prevention approach to achieve the U equals to U and the holistic care, incorporating the targeted prevention among the people with an HIV, and just as Roger said, which we're doing to trying to shift the bell curve, the normal distribution curve from the high risk or at risk back to on the left side of to become sort of approaching the normal risk curve. Okay, this is I just learned from Roger. This is a shifting of the curve. Okay, and we are able to sort of achieve the triple 90. Targets. proposed by the UNAIDS. This is a summary table of this is all with figures. This is specific and measurable as a program surrogate indicators. Okay, you see this is the coverage, the number of condom, the coverage, the number of tests, the number of condom distributed, condom usage, and this is the summary statistic. Okay, have a look. Okay, this slide will happen again. Okay, later. Okay. And the terms of reference of Hong Kong Advisory Council in AIDS to keep review local and international trends and development relating to HIV infection and AIDS, to advise the government on policies relating to prevention, care, and control of HIV infection and AIDS in Hong Kong, and to advise on the coordination and monitoring of programs on the prevention of HIV infection and provision of services to people with HIV AIDS in Hong Kong. This is the terms of reference of the Advisory Council on AIDS. I believe the key to success relies on wider community engagement, multi-sectoral, disciplinary organization, departmental, industry, national funding, lots of multi-sectoral responses, and active and even proactive participation, communication, and collaboration by people who are affected by HIV. Okay, this is the 2027 strategy. Okay, this is the approach: evidence-based community participation, the accessible and affordable by affected communities and whole society, cultivating a supportive and enabling environment, prioritizing funding and resources. This is the guiding principle. This is this slide. This is a recap of what we are doing. It's a so-called this is the community participation. But this is a recap. Okay, we have engaged the relevant NGOs, and different groups of consultation meetings, in various sections of consultation meetings, gather all their inputs, and the secretariat have summarize, collect and summarize their inputs, and eventually prioritize. Okay, and this is the effort of the community. The effort of the community. This is the way we try our best to engage the community to have their view and inputs to put up and consolidate in the strategic paper. Okay, in gist, red, highly in red. The strategy is not my strategy, not the Advisory Council AIDS strategy, but the strategies of us, me and you. Okay. This is the strategy of the community. It is not only the strategy of the Advisory Council on AIDS. Okay. And this is very, very busy. To summarize, we have one vision. One vision 30. One vision 30. 4 objective, 6 target group, 8 strategic area, and 10 surrogate indicators. Okay, just like propaganda, very easy to remember. It's one vision 30. 4 objective, 6 priority group, 8 strategic area, and 10 measurable indicators. Okay, I'm not going to given the interest time, I'm not going to give individual detail of this detail. And yes, this slide pops up again. Okay, I will draw your attention to the red highlighted thing. Okay, for this is what we have done in the strategy in 2017 to 2021. But now we have a new strategy from 2022 to 2027. We have there in the so-called strategic area. There is 3, which is not mentioned. This is not mentioned in the report. okay, is these three. Enhance, promote youth health sexuality education. Reduce and eliminate HIV-related stigma and discrimination. Mobilize the collaboration between government and the wider community, society to create change. These three, okay, that is, well, I'm sure in the year 2017 and 2021, okay, we are doing this three already, but for some reason, okay, we are not able to consolidate into figures, to tell people what we have done. And by the end of 2027, we write down, with a new term of strategic paper at the end of the 2077. I'm not quite sure whether we can put some of the indicator or a few words about what we have been done in this three particular area. Okay, this is the measurable indicators. Okay, this is a very boring. Okay, you can go to the original papers to the strategic paper to individual to read them. Okay, but basically, there's a triple 95 and plus one the 90% and the triple 95 goal. We set it on the in the strategic paper. We believe that well, this is the evidence base, and we are continue to we are going to continually monitor, evaluate the effectiveness, and strengthen our partnership and connection with you and the community peoples. And well, I spent a very short time on the hot topics in ChemFund and ChemSex. This has been discussed in one of the meeting. It discussed in one of the meeting on the Advisory Council on AIDS. Okay, thanks, Lisa, Dr. Yip. Okay, to making the presentation in the Advisory Council on AIDS. This is some of the highlights. Okay, about ChemSex, which is a very important emergent issues to be and challenge we are facing now. Chemsex refers to the use of drugs in a sexualized context by gay and other men who have sex with men, where specific drugs are used before or during sexual activity to sustain, enhance, disinhibit, or facilitate the experience. Basically, okay, the specific drug is mainly crystal ice, the GHB, G 水，大家知呢個嘅有個本地嘅名嘅，叫做咩啊？迷。Okay, yes, okay, 迷姦水 okay. This is the specific drug and the methadone, and this is a specific drug of concern. Okay, well, we know that, okay, there is a so-called the negative effects of the chemsex is physical health, in terms of the during sex, in terms of the toxicity, the organ-specific, the neurological, the neuropsychiatric and adverse effect of these chems. And during the chemsex, we have a good evidence to show that there's a high frequency of high-risk sexual behavior, including the number of sex partner, group sex, unprotected anal sex, and transactional sex. And this is the frequency of sexual behavior, and posing them at higher risk of contracting the all kinds of infection, sexually transmitted infection, hepatitis B and hepatitis C, and HIV, of course. And the mental health issue, which is a cause and a result of the use of this substance. Okay, to start with, this patient may have depression, anxiety. They have some pressure, social life pressures to start with. So they engage in chemsex. But this kind of mental issue can also be a result of chemsex. This is mutually reinforcing type of relationship. This is the scenario. This is the 6 1-year and lifetime chemsex preference among MSM. This is the local data. Was estimated to be 12, 15, and 6 to 19%. Okay, it is not low, which is not low, but I have no idea what is whether it is an underestimation or not. But this is the result of some local study, and the chemsex is linked to the social media and gay social networking apps, okay, and social networking apps. So this is some of the findings derived from this from the local surveys. And the psychological factors such as relief of pressure, curiosity, and boredom contribute to the practice of chemsex, okay? But the question is whether chemsex can eventually address their pressure, can address their boredom, can address their neuropsychiatric status. The answer is I don't think so, okay? This is also the data from the local study. The gist in this, the messages here is for those, for those who have people living with HIV, they have a reported drug use behavior, okay? And polydrugs is common, but there is 1/3 of them had coexisting mental illness. Most drug users never receive any form of drug treatment services. Okay, this is not only limited to the people living with HIV/AIDS who practice chemsex, but also for those not yet have infected with HIV/AIDS. The usage rate, the utilization rate of the drug treatment services was low. Okay, so in the strategic paper, it recommended integrated and multidisciplinary team approach to address this group of the chemsex issue and the capacity building. The capacity building is this is something that I observe is one of the NGO, the AIDS NGO, by training, they are not so well trained in counseling and capacity building, counseling and handling people engaged in drug using. For the conventional NGO who have focused on drug abuse, so drug abuse, okay, the conventional NGO, there's no well trained in HIV/AIDS, the gender issue and the HIV/AIDS issue. So we need to come together, okay, to mutually learn from each other, or to, if possible, to work together to work on this group of in this strategic area, okay. And the simple things is to let the AIDS services, including the clinical services, to facilitate early referral, pick up the patients and make appropriate referral, okay, to facilitate and to smoothen this route of referral, okay. And the challenges here, this is about chemsex, digital channel format of networking, and this is one of the challenges. This is not only for chemsex, this is for HIV/AIDS in general, the digital channels and networking, and the recreational drug MSM, the EM, late diagnosis, aging, inclusive society, okay. And the PrEP issues are all the challenges we are now facing, okay. Okay, this is clear player, but just give a clear player. But I want to recap here is the wider society. Don't forget those who are not interested but have competing interests. Okay. Almost finished? Yes. From the perspective, I'm used to be a government officer. Okay. I'm used to be a government officer, now retired. Okay. In doing the so-called every year we have to write the project submissions to ask for funding, project the service development. we are facing the dilemma of allocation. Whether the money should be spent on more on medical and health, housing, education, everything, welfare development. This is a competing interest. You know, there's somebody here. Okay, 唔麻煩事. Okay, you see, 唔麻煩事. Okay, okay, and then we have in coming back to the medical and health is whether we spend more money on prevention and on treatment. Okay, in terms of treatment, this is treatment for rare disease, and you know the SMA issues. Is the treatment is in terms of $1 million for one patient, $1 million for one patient, and this is for rare disease or common disease. Should we spend more money to better improve our diabetic service, and which disease? Okay, not mentioned, including AIDS and HIV. Okay, and treatment and rehabilitation, psychosocial well-being, the mental health issues. Okay, a large black hole right now. To attend more patients or versus spend more time in an individual versus health promotion, prevention versus research. These are all competing interests. And how to convince the budget holder and the public that the public money should allocate to a particular public services or policy. This is not only your difficulty. It's also my difficulty, okay, or when I was a government officer. Very difficult, this is something happens. This is illustrate. This is, 5 biscuit and 2 fish. 5 biscuit and 2 fish, you know that, okay? And we are competing in interest. Okay, whether it is wrestling or we join hand in hand, or we are, playing the tango. We are playing the tango. But I think we have to sit together and to better talk and communicate with each other. Okay, this is the last line. This is about the normalization. This is inclusive normalization that we cannot differentiate. You create a pattern, this type of pattern. Okay. It's very difficult. It's not difficult, but some people like to have this kind of pattern. It's a fully 全融合, fully inclusive. But some people, they like to remain their unique identity, segregate and create unique identity. Okay, well, which is the best? But we know that from the audience perspective, like you, do you like this pattern, or this pattern? Some people, they like this pattern. Some people, they like this pattern. Okay, it is very interesting. Let's think about it. What we are doing, what we should do. Okay, thank you.
So we'll now have the 10 minutes Q&A section. So because we overrun a bit, so maybe we can only have like a 1 to 2 questions. And 不過你哋可以一間coffee break 嘅時候 still have a lot of time to exchange。可以係啦。我而家有請埋Professor Zhong 係啦上嚟。Okay, thank you。好，隨便坐。你哋兩個可以自己講一日嘅，我覺得都會好好聽。係好，is there any questions online on the floor? Okay, if no questions, and then I will have you to go ahead to answer the challenge questions that Professor Roger been asking. How would addressing the social determinants look like in the context of Hong Kong? Your role as the chairperson of ACA. How will you see? How will you?
Well,
that's a big question. Sorry.
I'm sorry to put you on the spot.
Okay, it's a very big question. I think as a chairperson, as I said, my strategy is the so-called social determinant, and I'm going to use the platform of Advisory Council on AIDS, and maybe sometime where I may invite Professor Jones to make a presentations in the Advisory Council on AIDS meeting, and to enlighten the members of Advisory Council on AIDS, which is very specific. Okay, we can do it without difficulty. Okay, Lisa, what do you think? Yes, to share, to enlighten the members the issues of social determinant. This is one thing. The other thing is I still believe that we have to engage a wider community engagement, and we create some kind of platform or even meetings to engage some of the so-called people who have interest but not interested, okay, and to exchange with each other and But on that, we as workers, we have working in this field for many years, but we have to also be humble, myself, to listen to the people who have interest but not interested, what they actually think, what are their concerns, and this is a true exchange of idea, and it's possible we can engage them to address many of these, at least some of the social determinant, as Roger proposed it in his talk. Okay. Okay.
Cool. Thank you.
Oh, you're welcome. Okay. I wish I can address a little bit of your questions. Okay.
I think we can all take more time to deliberate on how we can address social determinants of health. Yeah, but that was good idea, and I accept your invitation.
Okay. Well,
Excuse. Hello. Yeah, I would actually. I've been thinking, because you put together health equity and the HIV. I look at the number there. I wonder if has there been any study on the socioeconomic status of those people living with HIV at all? Is there any? Because I think in Hong Kong, people have actually access to HIV care, like in the center in County Bay, or so has there been any study on these people living with HIV, and has there been any? Have they been denied access at all? All right, or apart from the social stigma or any other things? Thank you.
Do you know? Have you collected SES indicator in your studies?
Okay, I may pass the questions to Bonnie. Do you have any idea whether we are collecting this data?
Thank you for the question. I don't think at current we look at these social, their income and stuff. But usually what data that we're collecting would be the route of transmission, that route of acquisition of HIV. And but based on my frontline clinical experience, we are seeing people from all walks of life. And from those who are very marginalized, jobless, homeless people, to those who are so highly educated, getting more degrees than a lot of us do, and making a very very economically productive. So I guess it's well, as for Roger mentioned, here in Hong Kong we are offering, no one should be denied of medical care because of just financial constraints. So this is what we are doing. We're offering a lot of support to our clients who can't pay for the medical fee. And for those who even can't support the transport fee to our center, they are well taken care of by all, the support from NGOs, the AIDS concern delivery service, and our social worker has been on site providing support to them, facilitating the access to care. So, but it would be interesting, actually. I actually learned a lot from Roger's talk, and I do believe that there are room for collaborations to see how we can tackle it more deeply. How, instead of just offering a longer broom to those who are marginalized, how we're going to just remove the fences. Well, this is, a really nice picture. I usually come across the baseball one, but I'm going to use the new one in my future, sharing.
Sure.
But I definitely, will approach you and see how we're going to, look at this in a more scientific way to make things that's publishable, quotable, that we can use to convince the policymaker to help us, provide equality of care and equity and things to people who are in need. So that's my sharing.
Just add on your question, I myself is more on qualitative research, so I can provide you kind of figures, but through my own research and also my connection with AIDS Concern and also other NGOs in Hong Kong, there definitely a lot of disadvantages, for certain group of people, especially vulnerable groups of people, in terms of the way how they can actually access to medical or social services. For example, LGBT, especially older LGBT, and also female sex workers or male sex workers, and other vulnerable groups. But I can't provide you sort of figures, but I'm sure later AIDS Concern or maybe some other NGO people, they may share with you more the qualitative data or narratives to let you know a bit more about that. Yeah. So just want to add on that.
Just to follow up, I think it's a very good idea to do a more systematic, structured, empirical study on who are these people in terms of their socioeconomic background and education attainment, etc. And I think that would be a meaningful thing to go forward. Yeah.
And I'd like to actually supplement, because from our end, we are seeing a biased sample, because we're seeing clients who are linked to care. It's more often a time that we don't have access to those who fail to come to us. Exactly. Yeah. So it needs to be some concerted effort in the community to see, who these people are who fail to be linked to care. Mm-hmm. So this is the thing I want to supplement.
Yeah.
So I think we can have one more questions.
Thank you for the presentation. Just short question regarding to the social determinants of health. Yeah. What do you think about the PrEP adoption in Hong Kong? How could we to reduce the effect of social determinants of health when we would like to adopt the PrEP adoption in Hong Kong, especially for the young gay community, which can afford the private PrEP in Hong Kong?
That's a good question. Okay, maybe I'll supplement.
Yeah.
Okay. Me? Okay. PrEP? Talking about PrEP. Okay, okay. Yes, okay. And okay, put it this way. For the time being, we have the special preventive program. They have conducted researches or commissions. They have researchers on the utilization of PrEP among the MSM in Hong Kong, and I think we have some figures on it, but not sharing this in my talk. And most of the people who adopt PrEP in Hong Kong, they acquire the PrEP from Thailand, the PrEP tourists, and some of them acquire from the internet, and some acquire the PrEP from the local service provider, including NGO and including the private service provider. Okay, this is the group, but overall, the percentage of MSM who use PrEP is not very high in terms of it is. But one of the important observations in our survey is that when they acquire, say, for people who acquire the PrEP from Thailand, when they come back to Hong Kong, the adherence to the PrEP protocol, okay, and to secure the appropriate PrEP as prevention for HIV, acquisition of HIV prevention is not very good in terms of they may not take PrEP as we recommended. They do not attend for the regular STI screening. They do not attend for the regular checking for HIV. And this is some of the observation we have. But the key questions, I think, at the back of many people's mind, which is whether PrEP should be provided by through the public medical public services. This is your question. This is the center of key questions. I have said, okay, we have competing interests. Okay. We have not you and we are required to convince not only the government officer, not only the budget holder, not only boss, okay, not only the chief executive, but we have to also to convince the community as a whole, the local community, local people, the common people. We have to tell them, convince them to support such a policy of providing PrEP, okay, through the public medical system. This is I use the term, is the social marketing of the whole HIV/AIDS program. This is one of the area within this HIV/AIDS program. This is the social marketing. How we can do that? Okay, we have a good story for condom social marketing. To start with, at those years, promote condom, well, which is not a good idea. From the back of mind of many of the lay people. Okay, you are promoting condom. Are you promoting promiscuity? Okay, this is their mind. Okay, but after so many years work, so many strategy. Okay, now it is not the sort of we have a very easy to promote condom without giving the label of promoting promiscuity. Okay, this is the story of the condom social marketing. But in terms of this HIV/AIDS program, okay, we have to think how to convince not only the budget holder, the government officer, but also the community people as a whole. Okay, this is the answer I put up. Okay, you may ask, do you have any very concrete strategy? The answer, unfortunately, I don't have a specific and good solution. But this is why I said we have to engage the people who have the risk, engage the people who have interest but not interested, or have competing interests. This is the messages hidden in this short statements. Okay. Okay.
I think this is very good. I just want to supplement a little
Thank
bit.
you.
No, I think this is great, and I think I just want to remind people that when it comes down to public policy making, there are always different ethical principles that underpin policy making, and usually when it comes down to public health, it is always the utilitarian approach, the utilitarian argument that really trumps the other ones. Because when it comes down to public resources, then it is the interest of all the people in the society, not only a few individuals. So you have to strike that utilitarian balance, meaning that we need to prove that, you know, if PrEP is the one that we're concerned about, we need to prove that PrEP is not only cost effective, but also very effective, right? Effective and cost effective. And also it can maximize the benefits, minimize the harms better than other alternative strategies. So I think that would be, you know, if we can prove that and show evidence on that, that would be very helpful if we're talking about that particular intervention.
Okay.
Yeah.
Thank you. Okay. And any?
Thank you. So, I look forward. Maybe AIDS Concern and Dr. Hall and Professor Roger, we can do a research, together with the community, like to do. I do agree that like collecting evidence to prove the case, and also to continue to do different educations, helping people to understand more from the cultural perspective. People always think like what you said is a condom is like a taboo, like many years ago, but we distribute that. So maybe it will happen, like in years to come. But it's still like how we build the foundation, do the education, do the research. Okay, thank you so much. Thank you so much. Okay, 我哋會影張合照先啊，好冇啊？Okay, so we will take a group photo together.